Alright guys, welcome to the final lecture, osteoarthritis. We're going to touch base on rheumatoid arthritis and gout as well. First, let's run through a chronic pain case to kind of, first of all, highlight some applications to pain management and also to go through a calculation question. So this person is a 54-year-old male, significant pain during recent tumor resection surgery. He is currently using 10 milligrams of IV hydromorphone total per day via continuous infusion plus PCA, or patient-controlled analgesia, and an average of 20 milligrams of oral hydromorphone throughout the day as well. You're looking to get towards discharging him, and you'd want something long-acting orally, so converting to oral oxycodone is the goal here. So the step one is to get your conversion factors, and on the exam I won't give you a chart with conversion factors. For each problem I'll actually give you the conversion factor in the problem, so it should make things pretty clear as far as what you're supposed to use. And then from there it's just really simply canceling some units. So what you're going to do is you're going to take your conversion factor, so 20 milligrams of oxycodone orally, and then that's equivalent to 1.5 milligrams of IV. I've got H here for hydrocodone, just as an abbreviation, and then times 10 milligrams of IV hydrocodone. So what happens is your IV hydrocodones cancel, and you end up with 133 milligrams of oxycodone. So it's pretty straightforward. You just got to remember to use your ratios and cancel your units. This one is looking at the oral component, so he's consuming 20 milligrams oral of hydrocodone as well. So 20 milligrams of oxycodone to 7.5 of oral hydrocodone. That's our ratio. And again, we're multiplying by 20 milligrams of oral hydrocodone because that's how much he's using a day. And that gives you 53 milligrams of oxycodone. So we've got our total, which ends up being 186 milligrams of oxycodone oral. And now this is probably the tricky part that some people miss or forget, is the cross tolerance. So remember, we want to decrease by 25 to 50% when we're switching from one analgesic to the other, or one opioid, I should say, to the other. And from this math, you're seeing about a range of 139 to 93 milligrams. So does it have to be on one side of that or not? Is there more evidence for 25% reduction? It's difficult to say. I think that's just sort of a general recommendation. And the nice thing about having a range like this to target is it gives us some flexibility in with what products are available. I would say generally, if somebody's in quite a bit of pain, I would go on the higher end of that. So go closer to the 25% reduction versus a 50% reduction. But certainly it depends on, the patient response. You can always decrease the dose, and you can always increase the dose. So there's arguments on both sides of that debate. So once you have your range here, you're going to figure out your maintenance dose using available products. I won't expect you to know what products are available for the test, but I'll give you 4 choices, and only one of them will actually fall within the range. So I'm not going to give you 2 choices within the 25 to 50% and make you figure that out. All of them will either be outside the range, and then of course the right one will be inside the range. So oxycodone comes in a 60 milligram tablet. So if we do 60 BID, that gives us 120 total daily, and that's what we're looking for. So when you're converting everything somebody's using on a daily basis to a long-acting agent, we aren't looking at any breakthrough pain right away. So this calculation and what we did on this slide as well, it's all about the chronic pain management. So the other step after that is one I don't really care about you knowing, but just for reference, like technically what you would do is do about 10% of this maintenance dose, and that should be available for immediate release as needed use. So that would mean 12 milligrams of oxycodone per day should be the least amount that you have available for your patient to take for breakthrough pain. Now, most people just prescribe like 5 milligrams of oxycodone or Percocet tablets with 5 oxycodone, 325 milligrams acetaminophen every 6 hours as needed for pain. So if they took 2 of those every 6 hours, that could be 10 milligrams 4 times a day. So that's 40 milligrams, so you're certainly above that. But the thing about those breakthrough pain tablets is you can use it as a tool to help you understand how well your patient's pain is being managed. So For example, if they come back, so maybe you start them on this regimen. So you say, okay, I'm going to prescribe 60 oxycodone extended release twice daily, and I'm going to prescribe 1 to 2 Percocet tablets every 6 hours as needed. And they come back and they aren't taking any Percocet tablets at all. They haven't touched them, and they're a little bit. They say they're a little bit sleepy. Well, there's a dead giveaway that your maintenance regimen is too high, and you need to start scaling that back. The other side of the coin is that you have a patient who comes in and they've ran through all their Percocet. They've taken more than was prescribed possibly, or they've taken the max that was prescribed, and now they're requesting more. And you're in the position of probably wanting to increase that that maintenance regimen a little bit. So it's a fine line. Opioid management is very challenging. Ultimately, the goal is to relieve the person's pain, but you also want to give them the least amount possible so that it's easier to wean them off of it when their pain subsides. So hopefully, as solutions are found, some pain syndromes, there's not really a great surgical option. Some patients aren't surgical candidates, and there's might not be a good end in sight if they have cancer or something like that. But in a lot of cases, if we can move towards a better solution, like a surgical option or something like that, that might help alleviate some of that pain. That's the ultimate goal. So over time, it's nice if we can get that pain threshold down and slowly decrease the opioids so that we can kind of taper them down as we go. But sometimes that can be really difficult to do. So that's basically what I just said about the PRN medications on that first bullet there. Side effects, of course, if the patient's overly sedated, you've got too much on board. If they're overly sedated and still in pain, that's a tough one because you're kind of at a limit. You don't really want to push your current opioid dose, so you might try switching to something else. For example, in this case, we tried long-acting oxycodone, and let's say they're sedated on that. You don't really want to push the dose. They're still in pain. Maybe you switch to fentanyl patches. That's probably your only other option other than some other things. Remember to try using adjuncts as well. So NSAIDs, acetaminophen can have some synergistic effects, and depending on the other things going on, like for example, if it's spinal related or back spasm related, sometimes diazepam, which is a benzodiazepine, can have some synergistic effects as well. Okay, so let's talk about osteoarthritis, one of the most common pain syndromes in most primary practices, and it's just something that happens to most people as they age. So background, multiple factors can contribute to osteoarthritis: joint integrity, genetics, local inflammation, mechanical forces, age-related degeneration. What we're seeing, what most people see is just chronic wear and tear on the joints is going to cause osteoarthritis. Most people will be susceptible to osteoarthritis at some point in their life, just as the body wears down over time. It may be idiopathic, though. You might not necessarily have a specific cause. Generally speaking, one of the diagnostic things about osteoarthritis is that it's specific to an area or a group of joints. So maybe somebody's used their hands for a long period of time. They're a gardener or whatever, or maybe they've been doing heavy weightlifting for most of their life, and so they've been doing a lot of stress on their joints and their knees and their hips. Those are things that could happen. Or if there's one joint that's affected, that's kind of like if one knee is worse than the other, that's sort of the hallmark of osteoarthritis. But certainly it can be bilateral as well. And of course, there's some secondary sources listed there too. Our goal of therapy, we want to relieve joint pain, we want to control inflammation and swelling, and retain functions of daily living. Disease progression is usually irreversible at this point. We can't really slow progression. We'll talk about maybe some theoretical steps, but at this point, with analgesic agents, all we're doing is relieving pain. We aren't preventing the disease from getting worse. So, of course, there are non-pharmacologic ways we can manage that, but from a drug perspective, there's really no progression change. So exercise, physical therapy, weight loss, education, alternative medicine potentially, surgical options, of course, especially if it's like a joint pain. So getting somebody a hip or knee replacement will be maybe an ultimate solution for their pain in those joints. But you can't replace every joint. There's plenty of joints that we don't do anything with. So it's a question of how do you treat these different patients, and it's kind of a case-by-case scenario. Research is developing disease-modifying agents. Talk about DMARDs a little bit, which is abbreviation for disease-modifying anti-rheumatic drugs. But there's certainly maybe some applications to osteoarthritis, and maybe we can work with some of these drugs that are targeting specific types of inflammation. They might potentially help if we can modify the way their mechanism works to help osteoarthritis as well as rheumatoid arthritis. And we'll talk about that a little bit more in the next set of slides. Pharmacologic interventions add in a stepwise approach. So really we're going to approach it like the WHO ladder that I showed you on the last pain lecture. So we're looking at starting people with basics and then moving up. Ideally, we're avoiding opioids. For osteoarthritis, opioids generally aren't indicated, but it could be in some rare cases. Breakdown of cartilage between the bones. Bones grind together. It causes inflammation and pain. Okay, so our initial treatment, early osteoarthritis, a lot of patients probably self-medicate. They take, an as-needed ibuprofen or Tylenol that they're buying over the counter, and it works reasonably well for a period of time, but they might get to the point where it's just not helping, or they're waking up with a lot of pain, or they're getting points to the day where they feel like it's just not carrying through. Maybe they wake up in the morning, they take 2 Tylenol, they feel fine, and then by the afternoon they're in pain again. And so a strategy we can do is to switch those people from the as needed group to a scheduled, because if we're scheduling it, the idea is you're staying more on top of the pain. And that's sort of a general hallmark for any type of pain management, is you don't want people to have to react, because if they have to take a drug when they feel pain, it's a little bit too late. And then you've got absorption and distribution within the body. And it's going to take an hour or two for that drug to reach its max concentration. And you just aren't going to see benefit for very long. And, you might get some benefit after 30 minutes, but still, if you schedule it, you can try and stay on top of that in a little bit more of an organized fashion. So anyway, first line for osteoarthritis is always acetaminophen, and this goes for pretty much any pain syndrome. Certainly there's really aggressive pain syndromes where acetaminophen won't touch it, but acetaminophen, like I said, works, like I said in the last lecture, works really quickly for the most part. You should be able to get a response in 30 minutes to an hour, and if not, you move on to your next drug. Acetaminophen's very nice compared to NSAIDs because it doesn't have the GI bleed risk, it doesn't have the kidney risk. So for these patients who have osteoarthritis, a lot of them are going to be older, and older adults tend to have more weak kidney function, and we can avoid that possible problem with the NSAID therapy. So acetaminophen first line. I would have a low threshold for going to the 4 grams per day. 4 grams per day is the recommended dose for osteoarthritis. So schedule the acetaminophen, tell them to take 1 gram every 6 hours. If you're not comfortable with 4 grams, you could do TID as well. Certainly see if maybe you could try a lower dose and see if it works for the patient. And maybe they can get by on 1 gram twice a day or 3 times a day. But I would definitely do 1 gram each dose for osteoarthritis. I don't think a lower dose really touches it, but every once in a while you hear, I've interviewed enough patients at the hospital where I hear, sometimes you have an older person who says, well, I take, a regular strength Tylenol and it just knocks me out. And it's like, I don't think that's even possible pharmacologically, but it's still something you hear. So I'm not telling you to overdose your patients right off the bat, but don't be afraid to approach that 4 gram. And I think, again, scheduling it and staying on top of the pain is really important with this. Studies, if you're wondering how Tylenol does in studies, it doesn't do great. It says it's maybe slightly more effective than placebo, but a lot of people actually that I've, again, interviewed in the hospital will report that Tylenol works for them. So for me, I can take Tylenol and I feel like I just, might as well have not done anything at all. But for some people, they do get an effect from it. So again, certainly worth trying. Relatively harmless, especially in the controlled dosing. So again, that 4 gram a day, I want you to know that threshold, and that's the cutoff of your max dose. But it's certainly okay to approach that 4 gram and get right up to it and dose it as 4 grams a day. Okay, so if acetaminophen fails, or some people would argue that if you have evidence of inflammatory osteoarthritis, so maybe if you have a swollen knee joint with effusion going on, you go straight to an NSAID. NSAIDs are usually given scheduled, so but of course people can take them as needed as well. And the question will become, well, what if you're mixing and matching? Maybe you start somebody on 4 grams a day of Tylenol, they're getting some relief, and then you add on some as needed NSAIDs. Is that okay? Yeah, sure. But at the same time, if you have a really inflammatory component to your osteoarthritis, you might just want to skip to the NSAIDs altogether. Now, certainly there are patients, heart failure, cardiac risk, that just can't take NSAIDs for whatever reason. But for the other patients out there, I would say, definitely consider going to it, especially if it's inflammatory in nature. Usually, again, we're giving it scheduled, and the thing is, if you give it PRN, you might get some analgesic relief. But if we really want to suppress the inflammation, you really have to have round-the-clock NSAID therapy. 2 to 4 weeks about to assess the full efficacy. So really to see the overall effects of suppressing inflammation for a long period of time. That's the time frame. Now certainly you're going to get analgesic relief before that, ideally, but over time NSAIDs can help with that suppressed inflammation. Most studies will say that ibuprofen, there's a lot of head-to-head studies with ibuprofen and acetaminophen, and almost all of them will say that ibuprofen is better for analgesic relief. No real surprise there, but that's most of the literature. Use caution due to risks again. Elderly patients, whenever you're thinking about an NSAID, just double check what's going on, make sure their kidneys are relatively healthy. Use the smallest doses possible for the shortest amount of time you can get away with. Now, if you're scheduling it for 4 weeks, that's kind of a long time. So again, be careful with those patients who are high risk. Prostaglandin E2 may contribute to OA-related symptoms. So there's a specific type of prostaglandin that's thought to be have some NSAID or some inflammatory contributions to the pain syndrome that OA patients are experiencing. NSAID choice, again, there's not really an NSAID that's better than the other. There's a lot of different factors. Patient response, certainly if somebody's not getting a response from one, you could definitely try another one. They're all pretty much the same, but people might get different experiences with different ones. Side effect profiles, all pretty much similar. Somebody has a history of a GI bleed or anything like that, whether it's upper or lower or whatever, I would be a little bit hesitant with NSAIDs. But if you're going to use them, maybe try the COX-2 selective NSAIDs, Celebrex. And of course, you would want to couple that with something that suppresses acid, so like a proton pump inhibitor like Prilosec or Nexium. That is your best bet for not causing any type of GI bleed. If they have a history of substantial GI bleeds and they're on warfarin and or some type of other anticoagulant, I'd be really hesitant to prescribe an NSAID. Some other types of again, the type of osteoarthritis, is it inflammatory or not? Frequency of administration can be a thing. So if somebody says, well, I'm getting good response, but I can't remember to take my ibuprofen 3 or 4 times a day, maybe switch them to naproxen, which they can take twice daily. Cost, fortunately, most NSAIDs are quite cheap. Even celecoxib is going to be probably a little bit more expensive, but is generic now. And again, you can get ibuprofen and naproxen over the counter in massive quantities for very little amounts of money. So insurance doesn't always pay for those because they're OTC, but most people can afford them, fortunately. Again, naproxen, ibuprofen are your first two. I would say I'd lean towards naproxen just for the convenience sake, and also it has been studied to show it has the lowest overall cardiovascular risk of all NSAIDs. Oops. Don't forget about topical products. I feel like I said this before, and I'll say it again, that topical products are something that people don't keep on the forefront of their mind when they're thinking about pain management. And I certainly think it's something we should be thinking about more. Diclofenac gel and patches, you get some systemic absorption, but a lot lower risk for side effects. And these drugs are not as maybe convenient because somebody has to apply them topically, but certainly effective. Capsaicin is something we haven't talked about yet. It's actually its active ingredient is derived from the component of hot chili peppers that causes them to be spicy or hot. The mechanism of action is that it rapidly depletes substance P, which diminishes pain signal transmission. It has mild to moderate efficacy. Again, this is a topical product, right? So this is a cream you're applying. You may have seen capsaicin cream on the market. It's over the counter. And there's no real systemic absorption or effects. However, of course, this is derived from peppers, so be really careful what areas you're touching, eyes or other places that obviously would be sensitive to hot chili peppers. And then lidocaine patches. Lidocaine patches were designed for post-herpetic neuralgia, but the use of them in other pain syndromes is possible. So especially if somebody has osteoarthritis in their back, or um, maybe a shoulder or something like that, where a patch might work. You could certainly give it a shot. For smaller joints like elbows, knees, it might be difficult to put a lidocaine patch on there, and I'm not sure how much benefit you're going to get, but certainly it's a relatively benign thing that's not going to cause a lot of systemic issues, so it could be worth a shot for patients. Steroid injections. So we talked about steroids last fall, but and we didn't really talk about them with respect to pain yet. Steroids are something that can help with different types of pain syndromes. We'll come back to these a couple times. We'll talk about their use in migraine headaches. They have a lot of different roles as well. So the idea is that so think about the word NSAID, non-steroidal anti-inflammatory medications. So steroids, like corticosteroids, have an anti-inflammatory approach to them as well. So the idea is that you're getting a anti-inflammatory response from a different mechanism of action. So you could combine a steroid and an NSAID if you wanted to, or you could just do steroids. Sometimes we'll see steroids combined with other analgesic medications like opioids for different types of pain syndromes as well. But steroids are certainly an option within the realm of pain management. And for intra-articular steroids, this is a nice way to administer a steroid without really having any systemic side effects. So that's the big deal with steroids, is that they have a lot of nasty side effects when you give them in prolonged durations. So in this case, what we're doing is injecting a long-acting, it's basically like kind of an oily suspension type product, and they're going to sit in a joint synovial space and cause a local anti-inflammatory response. You could possibly get some systemic absorption effects, but it's going to be minimal. Consider these if only 1 or 2 joints are affected. If somebody's got like 10 joints that they're having osteoarthritis in, it's just not practical to give that many steroid injections. But if somebody has like a really bad knee that's bothering them, it can certainly work quite well for that. You hear athletes using these a lot, so you hear about cortisone shots or cortisone injections. That's what they're talking about here. You can use for patients who are maybe in really severe pain and nothing else is touching them, and you don't want to go to an opioid, and or a patient who has NSAIDs that are contraindicated or NSAIDs aren't effective. Usually benefits are seen about 2 weeks after the injection, and they wane a little bit after that. Injections can be repeated at 3-month intervals, but you can get diminishing returns with them, so you might not get as good of efficacy with that second or third shot as you did with the first one. The drugs we use commonly are triamcinolone. Triamcinolone is also known, you probably hear it, I think I said this in the steroid lecture, but Kenalog, if you ever hear a Kenalog injection, that's probably the most common one that's done. Methylprednisolone also comes as something called Depomedrol, is the brand name. Depomedrol, and that is another kind of oily formulation that you can inject into a joint space. It's really important, and this is maybe obvious, but these products are much different in their formulation than something we'd give somebody intravenously. If you inject somebody with this oily stuff IV, it could be disastrous. So be really careful which product you have, and if you gave something that's not designed for a joint space into a joint, what you're probably going to do is it's going to disperse and get systemically absorbed, and it's not really going to be all that effective. So make sure you're using the right product if you're doing any of these intra-articular shots. Dosing is kind of all over the place, but generally speaking, if you have a larger joint, you're going to be using a larger dose, but the dose is a little bit, I would say, not scientific. We're just giving some and hoping that it stays in the joint space and provides a good response. It's not really a science as far as how much you're giving. Glucosamine and chondroitin, these are OTC supplements. A little bit controversial because there's not really any compelling evidence to use them, but there is a lot of use of these, and they're kind of expensive for supplements, I would say. But there isn't really a lot of evidence that says there's any danger to using them either, so they don't have a lot of side effects associated with them. There are some, if we're going to look at all the evidence, there are some studies that may point to mild preventative benefits. So it's interesting because this is one of the only products we have that there's even anything that says that it could help prevention of osteoarthritis from a pharmacologic perspective. So again, it's sort of a benefits outweighs risk. If your patient can afford it and wants to try it and you know, is really gung ho about taking it. I have no real problem with it. I would just make sure that they understand that there's not necessarily likely to be a strong benefit with it. However, it probably won't cause any side effects either. So again, a lot of people take these, but the evidence is quite questionable. The mechanism. So glucosamine is a product that supposedly prevents inflammation and cartilage degradation, and chondroitin should stimulate proteoglycans, which theoretically helps to build new cartilage. So I don't know. Again, it's a little bit of a of a of a controversy when it comes to whether or not this product really works, and it gets a little bit confusing as far as like the supplement category go. We haven't done our supplement lecture yet, but we'll talk about supplements and their definitions in a little bit. But again, very widely popular supplement that a lot of people take, and certainly something that might be worth trying for some patients if they want to take it. Again, I really don't see any problem with it, but I just wouldn't say that take glucosamine and chondroitin. It will definitely help your osteoarthritis, because they probably won't get any effect from it that's noticeable or measurable. Okay, so for OA, and I picked OA because it's a common pain syndrome. It represents how we treat a lot of pain, so this isn't really all that different from, you know, any other pain syndrome. But our initial treatment is going to be non-inflammatory processes, going to be acetaminophen, exercise, and weight loss. Those are the best things we can do. If somebody fails acetaminophen, or there's obvious evidence of inflammatory an inflammatory component to the joint, we're going to use NSAIDs, so naproxen or ibuprofen. Then we might move to other NSAIDs. Consider steroid injections either after NSAIDs aren't working fully, or if there's a contraindication to NSAIDs. Physical therapy would be maybe something to consider at this stage as well. If you fail multiple NSAIDs or have serious adverse reactions, steroid injections can still work in this category, but they're only going to work for so long. So I always think of a steroid injection kind of as like a bridge to something else. So either you're going to solve the problem with a joint replacement, or you're going to solve the problem maybe with some physical therapy, but ultimately steroid injections can only get you so far, because they just aren't something that you can sustain for chronically for years and years and years. Your benefits are going to diminish substantially after a few shots, and at that point, the drug's not going to be all that effective for you. At the end of the day, opioids would be kind of your last line. Certainly, they would probably work for this, but we want to avoid them as much as possible. And that would go for really any pain syndrome out there. All right, rheumatoid arthritis. So rheumatoid arthritis is different than osteo in a number of ways. So usually it's more severe. It's caused by the immune system attacking the body, so it's an autoimmune disorder. So our treatment strategy, while is similar in some aspects, is very different in others. Usually when we see osteoarthritis, it's older patients. Rheumatoid will show up in younger patient populations. Symptoms can be systemic, whereas osteoarthritis usually just located in the joint that's affected. And rheumatoid arthritis affects more women than men, as is pretty common with a lot of autoimmune diseases. Commonly found in both men and women for osteo, so some differences in the disease presentation. Our treatment is focused on control of joint inflammation and injury, and again, we talked about the differences. The pathophysiology is different. It's an autoimmune disease. It's attacking the joint space. One thing about rheumatoid arthritis is that usually if somebody has it, they have bilateral symptoms. So it's going to affect joints on both sides of the body, where with osteo, a lot of times we will see unilateral symptoms. Treatment and identification. So identification and referring to an expert. This is something that a rheumatologist should probably manage initially, or somebody who works in a rheumatology clinic, which certainly could be you guys. We want to achieve as tight control of the disease as possible. Frequent monitoring is required. And then we have a whole arsenal of analgesic medications we can use, but really the cornerstone and what makes this a big difference in treatment is we're going to talk about drug modifying or disease modifying agents, or the DMARD class. All rheumatoid arthritis patients should be treated with DMARDs, and again, we're basically using analgesics as supplementary. Okay, so diving into our DMARD options here, there's a couple older drugs that aren't commonly used quite as much anymore, so I'm not going to spend a ton of time on them. But hydroxychloroquine, sulfasalazine. Hydroxychloroquine or Plaquenil is pretty well tolerated and can be effective, but it's just not quite as effective as some of the newer agents out there, so it's sort of lost its luster, I think, but it's certainly worth trying. It's pretty inexpensive, so compared to some of our newer agents, which are very expensive, this one could be an option for patients with cost-prohibitive issues. It was actually an anti-malarial agent originally, but they find that it has some modulating effects on neutrophil and eosinophils, and so that helps with helps cause some anti-inflammatory effects. Sulfasalazine is a drug that is primarily used for inflammatory bowel disease, and there has been some, theoretically, it doesn't even get absorbed out of the GI tract or have any effects, but some people find that it does work with rheumatoid arthritis, so it's interesting, because I don't think we have any real understanding of why that would be. Why would it have systemic effects, other than there's something going on in the GI tract? So it's possible this could work for people, but it's not going to be usually a first line. So with, let's say somebody's on hydroxychloroquine, usually what you'd be looking at is adding NSAIDs and glucocorticoids on top of that to kind of form a base of your anti-inflammatory effects and your drug modifying effects there. 12 to 24 weeks usually of a trial, and then once that's done and they aren't getting success, you might consider a different drug at that point. Methotrexate for a long time was sort of the gold standard for a lot of different autoimmune diseases, and especially rheumatoid arthritis. It's a folate antimetabolite, and no one really knows. It's got some chemotherapy properties. I mentioned it during the chemo lectures, but no one really knows why it works exactly for rheumatoid arthritis, but it's thought that it has some immune modulating effects, which probably is obvious, but no one really knows exactly what those immune modulating effects are. This is technically historically reserved for more moderate disease, but methotrexate is arguably probably a first-line agent nowadays. It's got faster onset and comparable or greater efficacy than the drugs we just talked about on the other slide. You can combine it with other disease modifying agents, so you can combine it with hydroxychloroquine, you can combine it with some of the newer injectable drugs we're going to talk about here in a second. And depending on the practice setting, again, this is how the rheumatology clinic wants to practice. This is probably going to be a more common first-line option than the ones we just talked about. Dosed orally once weekly, which is a little bit tricky for patients, but it's usually like a large dose one time a week is pretty commonly how you'll see it done. You can also give IM shots of it too, so once weekly IM injections. That's not uncommon either. Side effects, it's got a few. May cause myelosuppression, liver dysfunction, pulmonary fibrosis, and GI issues, which sounds great. So for this drug, we have to do quite a bit of monitoring, especially with respect to blood dyscrasias, making sure we're watching out for those. So CBC monitoring, LFT monitoring to watch out for liver dysfunction. And a lot of patients will discontinue the drug, mostly due to the GI issues. That's the big one. For tolerability. So while no one's going to die from GI issues from methotrexate, and most people aren't going to die from myelosuppression or liver dysfunction from this drug either, but these are a bit more serious in my book. You've got immune suppression, you've got possible hepatic toxicity and failure here. Pulmonary fibrosis could be quite bad as well, more of a chronic effect. But GI issues are going to be what people experience day to day and what's going to cause them to just simply stop taking the drug. The drug is also teratogenic, so it's not useful in pregnant patients, which, if you think about rheumatoid arthritis, does happen in young patients, does happen in female patients. So our women of childbearing age who want to start a family, that's a big problem for them, so we have to watch out for that. It is a folate antimetabolite, and it modifies how the body uses folic acid and can suppress the way the body functions with that. So we supplement with folic acid to provide the other systems that are using folic acid to be more effective that way. Leflunomide is sort of a methotrexate alternative. It's not a folate antimetabolite, but it does have some antimetabolite similarities. It's a purine synthesis inhibitor, which causes some anti-proliferative and anti-inflammatory effects within different areas of how the immune system functions. And it's considered a methotrexate alternative. It's basically comparable to methotrexate It's for somebody who might not be able to use methotrexate due to cost or regulatory issues. However, the side effects are pretty similar. The teratogenicity is pretty similar. The discontinuation rates are similar. There's not a whole lot of difference with this. So why somebody would be on leflunomide versus methotrexate, it's debatable. Maybe if you had GI side effects with methotrexate, you could try this and hope that your patient doesn't get it, but I'd say your chances are probably slim because they have very similar rates. So anyway, some insurances may pay for one or the other, or I think leflunomide is actually a once daily medication too. So if your patient's having a hard time remembering Q weekly dosing, which a lot of people could have difficulties with, this could be an option potentially that's a little bit more traditional dosed. All right, and TNF alpha inhibitors, we're going to come back to these. We're going to talk about them today. We're also going to come back to them during Crohn's disease and talk about them a bit more. So we'll get them again. So if you aren't totally getting these, know that we'll come back and discuss them in a little bit more detail during GI illness. TNF alpha inhibitors, or tumor necrosis factor alpha inhibitors, are drugs that have been extensively used for autoimmune diseases for quite a few years now. You've probably seen ads for these out there, and they're some of the best-selling drugs in the country. First of all, they're popular, and second of all, they're really expensive. So when you combine popularity with a high price tag, you get a big dollar amount as far as number of dollars spent per year on these drugs. So these are big money makers, and they're biologic agents. So if you know, I kind of mentioned this at the very beginning of the year, but to review what biologic agents are exactly, these are large molecule proteins that are synthesized using different types of techniques, sometimes PCR, sometimes other techniques. And what we're getting is a synthesized amino acid chain that's going to be injected into somebody. So the process of making that, packaging it, and getting it to good stability is a lot more challenging than making a single dose oral tablet. And because of that, these drugs are really expensive. And because of the way they're manufactured and the differences in patents surrounding them, it's not legal technically to make a generic of them. But there was some legislation passed a few years ago that allows people to make what's called biosimilar products. Now, biosimilar products would be probably exactly the same. They're kind of like a generic of a biologic, but the big difference is the cost. So the cost of a biosimilar might be like 80% of that of its brand name equivalent, which is an okay cost savings, but at the same time, you're looking at still a very expensive drug to manufacture. And a lot of generic companies aren't going to want to get into that business because it's just so cost intensive. So they might just ignore it altogether. So my whole point in this is that we aren't really going to see cost-effective alternatives to these drugs probably anytime in the near future. We might see some slight price reductions here and there with some of the new biosimilar products that are coming out. But for the most part, it can be difficult. And oftentimes if somebody comes out with a biosimilar, they get sued by the original company saying they can't do that. So there's a lot of legal stuff going on too. So these drugs are, I think I've got some more on the exact mechanism and some more of the drugs here on the next slide. But basically, unless these drugs coming down in cost, which is unlikely in the near future, methotrexate's always probably going to be first line because it's relatively cheap. There are a lot of these drugs out there right now that may work, but the two that are most common and have been the hallmark for RA treatment have been the two that I've bolded here. So adanercept, which is Enbrel, and adalimumab, which is Humira. And there's a couple newer agents as well that have been studied in combination with methotrexate. And remember that these drugs can be used in combination with methotrexate. And some of them, again, these two specifically, were actually studied that way. Okay, so you notice this slide isn't in your deck. I realize that I didn't put it in this lecture, but here's a quick illustration so you can pause it and take some notes or look at it. I'm not going to test you on the mechanism of a TNF alpha inhibitor because they're complicated, and I really don't care you know anything about them for a test purpose other than that they are TNF alpha inhibitors and they are this group of drugs. This is from my Crohn's lecture, so I just stole the slide quickly. TNF alpha inhibitors. So here we have infliximab. You could put adalimumab or etanercept in here as well. You have a TNF alpha receptor. So tumor necrosis factor alpha is a naturally occurring thing in the body that causes a lot of inflammation based on how it interacts with different parts of the immune system. So what we have here is a TNF alpha receptor. And our drugs are basically either blocking the receptor or they're binding to the factor itself and making it so it can't block the receptor. They work both ways, but they're usually these big proteins that kind of glom onto the TNF, the tumor necrosis factor alpha itself, and then it can't really do anything. But the process that would happen naturally, if unchecked, is that you get cellular apoptosis, production of inflammatory cytokines, and apoptosis of the macrophage here, increased expression of cell adhesion to molecules. So you get a number of different downstream effects, most likely causing the big one being for what we're talking about now with rheumatoid arthritis, and also for other autoimmune diseases that cause inflammation, is this production of inflammatory cytokines, which is a something the macrophage will produce, which can be quite aggressive, especially again like with a disease like rheumatoid arthritis. So anyway, that's what tumor necrosis factor alpha does. If we can block that process, we can actually have a really big impact on this disease, or on these groups of autoimmune diseases that are heavily dependent on this factor for causing their symptoms. If we can modulate that, we can prevent that substantially. Okay, back to this lecture. So our different inhibitors on the market, just to go into them a little bit more detailed, Enbrel is one of, I think, the first one on the market. But anyway, it's pretty well tolerated. Originally, it was designed to be used for patients who failed methotrexate. This was designed in the days when methotrexate was first-line gold standard. And now, even though methotrexate still is cheap and probably first-line for most people, these drugs would be preferred. If we could have everybody on these drugs, that's probably, now don't quote me because I'm not a rheumatologist per se, but I would think if it was me, I would prefer to be on one of these agents. Why? Because they have a better side effect profile overall. And remember, if we think about 30% of people potentially discontinuing methotrexate due to GI issues, these have none of those side effects. So really, what are we at risk for with using these medications? First of all, is increasing our healthcare costs, but we're already using these really, really readily. So sort of like we've kind of jumped the shark in that, I don't know, that ship has sailed. We'll use that analogy. That's probably a better one. So I don't know really how much people care about the cost of these anymore. And I think actually insurances are starting to pay for them reasonably well. They might say, hey, has your patient tried methotrexate? And you might have to fill out some paperwork saying, yes, they did. They had terrible diarrhea. It wouldn't resolve. We tried Arava or leflunomide. That didn't work either. Can we do Humira? And the insurance company would probably say, yep, sounds good. Simply put, these drugs give really good results and people tolerate them quite well. They are injectable, so there is that maybe thing where some people don't like injecting themselves with stuff, but at the same time, these are highly effective medications. So anyway, Enbrel originally designed for patients who failed methotrexate. Side effects are very minimal with any biologic agent. The one big side effect for them as a total group is anaphylaxis and local kind of irritation with the injection site. Those are the two big ones. The reason being is that proteins in general are going to be much more likely to cause an immune response than like an oral tablet, especially if you're injecting them into somebody's body. Now, still quite low risk, but still something we see more commonly than with our average drugs. The other thing is local irritation with injection site. This can be maybe mitigated a little bit by rotating if the person's getting it, or switching to a different agent. So if you get irritation with Enbrel, try Humira, and vice versa. These drugs do have some immunosuppressive properties, but for most people, it doesn't cause any increase in risk of catching any type of illness. It's not like they're totally immunosuppressed like somebody on transplant medications or something like that. But it can put you at risk for latent infections to get activated. So most of the time people have to get a baseline tuberculosis test, like a PPD, to make sure that they don't have any latent TB, and also hepatitis testing. Those are the two that we've seen can get reactivated if somebody has a latent TB or a latent hepatitis infection. Other than that, Again, very few issues with this. Most people go about taking these medications with very little risk whatsoever. Evidence shows that these probably are more effective than methotrexate. Methotrexate, again, is quite effective. It's just a lot of people don't tolerate it. So when you add the tolerability onto this, you're definitely, I think, could make an argument this is the superior product. I'm not trying to sell these, by the way. I'm just pointing out facts. Once weekly, if I was trying to sell these, I'd probably be doing a very different career path than I have right now. But anyway, once weekly dose for Enbrel, $700 per dose versus Humira, which is dosed twice monthly or every other week, $1,500 a dose. Very similar costs, very expensive. So you're looking at what, $3,000 a month or so, give or take, a few $100 here or there. So again, not cheap if you're looking at yearly total costs, but most insurances are paying for this. Very few patients are paying for this out of pocket. If they have to pay out of pocket, they probably aren't taking it. So they're probably taking something else. Infliximab is a IV medication. So these ones are subcutaneous shots. And infliximab would be an IV-only agent. It's been studied for use with methotrexate, so that's how it's designed to be used. Certainly, just because something was studied for use with methotrexate doesn't mean you have to. So the question might be, well, if somebody doesn't tolerate methotrexate, can you use infliximab? Sure, yeah, you can. It's just it wasn't studied that way, so kind of take that with maybe a little bit of a grain of salt, but that's the way it was. Remicade is a agent that you'd give every 8 weeks after a specific initial there's a loading protocol involved with the first series of doses. After that, it's every 8 weeks. So this would be something you'd have to go into an infusion center for. Again, why do patients use this over the sub-Qs? Not generally, but it is done in some cases, and some patients might get a better response from it. Slightly different drug, similar mechanism of action. So again, maybe they get a better response, but more likely that it's going to be very similar to the other two drugs on this slide. Some other non-tumor necrosis factor alpha biologic agents, abatacept or Orencia is an injectable that inhibits T cell activation, and most synovial fluid that's been studied with rheumatoid arthritis patients has activated T cells in it. It's got a loading dose, monthly infusion, IV. Otherwise, it comes as a sub-Q shot once weekly as well. Tolerability can cause some headaches, and respiratory infections have been seen more commonly with these than with the TNF alpha agents. Tocilizumab or Actemra is an antagonist of interleukin-6, which interleukin-6 is responsible for inflammatory stimuli and mediation of immune response. So there's a different immune system mechanism there. IV every 4 weeks or sub-Q once weekly or every other week, depending on the dose you give. Adverse reactions, that's my ADRs there. Sorry for the weird abbreviation that I don't use very often. Increased total cholesterol, liver enzyme elevations as well, and possibly neutropenia and thrombocytopenia. So these two drugs not quite as well tolerated as our TNF agents, but they do represent alternatives, which is always good in a disease like this to have some different options to work with. Rituximab, we talked about this briefly with transplant. It's a more broad spectrum agent, would be used maybe in more severe cases. I'm not going to go through all the details on there. It could be more rare for rheumatoid arthritis to use Rituxan. And then tofacitinib, which isn't a biologic agent. It's not injectable, so keep that in mind. However, this is still very expensive. It's $2,800 for 38 to supply. So it's basically priced like a biologic, but it's an oral small molecule drug. It's part of a group of drugs called tyrosine kinase inhibitors, which I mentioned briefly when we talked about oncology. If you remember imatinib or Gleevec, similar how this drug works. Anything that ends in INIB, you can think about as a tyrosine kinase inhibitor. Those drugs are all kind of in the same group where they all have astronomical pricing associated with them, even though they're small molecule and biologic. Anyway, and non-biologic, excuse me. Anyway, so this is a twice daily medication. What it does is it inhibits this group of enzymes called Janus kinase, which are a subtype of tyrosine kinase. And those enzymes particularly are involved in stimulation of hematopoiesis and immune cell function. So it impairs some immune cell capabilities that way. This drug was not studied in combination with other biologics, and it's not recommended to be used in combination. Where a lot of these other agents could theoretically be combined, and a lot of them could certainly be combined with methotrexate. This one is supposed to be used on its own. It does have an increased risk of overall infection with it, likely due to some more broad-spectrum immune suppressant effects. And again, very, very expensive. But it's oral, so you're getting kind of biologic level treatment with this, like a TNF-alpha would provide, but it's an oral medication. So there's maybe an advantage there for some patients. All right, so RA, initial treatment, and I should maybe whoops, sorry, skipping slides here. Initial treatment, I'm going to bold methotrexate. I think in this day and age, methotrexate is probably what most people are going to go to right away. Certainly hydroxychloroquine, sulfasalazine, probably available, could be combined with methotrexate as well. Leflunomide is a methotrexate alternative potentially. Methotrexate isn't working, or you're failing triple therapy. Triple therapy would be these three together. That's what I'm referring to here. So all three of these. Or you could sub in leflunomide for methotrexate. You never combine leflunomide and methotrexate. Remember, it's one or the other. So if you try all these, you're going to be looking at your primary TNF-alpha agents that have been used for years and years, and we have pretty good track records with. So adalimumab or etanercept would be the two to consider right off the bat. Most of the time, insurance might direct you towards one or the other. They might say, you might prescribe Humira, and they say, nope, we cover Enbrel, though. So you're like, okay, we'll try Enbrel. If they don't respond to that, methotrexate plus the tumor necrosis factor inhibitor would be an easy choice to try, assuming they tolerated methotrexate. So failed could be tolerability or efficacy, right? So failed could be due to side effects, or it could be due to the fact that the patient just didn't get a response from it. The patient got a response from it, and they don't have side effects, but the response isn't where you want it to be. Maybe you just add on the TNF-alpha agent, never take off the methotrexate. So that would be something to make as a clinical decision with each patient. There's never, and a lot of times you guys are probably getting this so far, there's not like a clear-cut path sometimes. You have to be flexible when you're making these recommendations, but generally this is sort of the approach you would take. Other things you could try, those other biologic agents that are newer. Not that there's anything wrong with some of them, but they're probably similar cost to our TNF-alpha agents. But we've studied TNF-alpha agents for 10 years. We know they work pretty well. So those are still going to remain our drugs of choice for kind of this middle tier of RA patients. If they don't respond to that, we're going to switch TNF-alpha agents, maybe consider rituximab, and then remember that Xeljanz is an option too as an oral therapy for patients. And all of this, don't forget that you can still use things like ibuprofen for breakthrough pain. NSAIDs will work well for people with these symptoms, but ultimately chronically it's not going to provide benefits, so we need these DMARDs on board to work with that. All right, gout. So gout is a really painful syndrome that causes very strong inflammation response in a particular joint. A lot of times people associate it with the joint of the big toe, but it can happen in other different joints too. The pathophysiology is associated with high levels of uric acid, which builds up and crystallizes. It's referred to as the disease of kings, where, king being a person who sits around a lot, eats and drinks a lot, and doesn't really move because they don't have to. I think about Robert Baratheon from the Song of Ice and Fire Game of Thrones series as sort of being my typical gout patient here. And yes, I know there's another character in the book that actually did have gout, but he's more obscure. So we'll focus on Robert because I think he looks like he could maybe have gout, or certainly he would have gout if, well, I won't spoil Game of Thrones for anybody who hasn't seen it. But anyway, disease of kings, obesity and activity, alcohol consumption, high protein diets are associated with gout. Acute treatment. So NSAIDs are still a very viable method for this. And then there are a couple other things we can try. Colchicine and steroids would be kind of the two second lines. Finally, there are some biologic agents available for this too, and some preventative medications we can take as well. If somebody gets an acute gout attack, we want to start the attack as soon as, or start the treatment as soon as the attack is coming on. And usually stop the treatment about 2 to 3 days after complete symptom resolution. Usually an attack is about 5 to 7 days in total is your treatment if you're starting within 12 to 36 hours of symptoms. So should be able to limit that attack to a reasonable amount of time frame. Chronic medications are not helpful during the attack. So if you're taking, we're going to talk about allopurinol, which is a chronic drug that suppresses uric acid production. But you wouldn't stop the allopurinol. But if somebody comes in with a new gout attack, starting allopurinol is not going to help them acutely. It will help them chronically, though. So NSAIDs. NSAIDs are our first line therapy. Naproxen is fine. Indomethacin has been studied extensively in gout, so you may hear providers say, oh, I always use Indocin for gout patients. Well, that's because it was studied that way. But remember, NSAIDs are all essentially the same. There's no real reason why you can't use ibuprofen. And there is literature to support that ibuprofen is very effective in gout, as effective as indomethacin. So certainly don't feel like you're stuck with indomethacin, because indomethacin is prescription only. You can buy ibuprofen over the counter. It's easier for patients. Everybody's got it at home, yada, yada, yada. Best if you initiate within 48 hours. And then again, we have our NSAID contraindications we're going to come up against. So the question is, what do you do if you have that? Well, second line is usually thought to be glucocorticoids. So whether it's oral, which is going to be perfect for most patients, you give somebody an IV dose if you want to start them out that way and then transition them to an oral regimen for the remaining of the course. Intra-articular injections could be useful as well for people who aren't getting good oral response. Again, you have your standard glucocorticoid side effects. Hopefully you're only using them for 5, 7, maybe 10 days. So theoretically you aren't going to see a lot of side effects. But if your patient's diabetic, you could get some blood sugar swings. You could see some of those mood changes or aggressive behavior that sometimes people get with corticosteroids in the acute phases as well. But those would probably be the two big ones to watch out for as far as side effects goes. Shouldn't see any real chronic stuff that we would associate steroids with. Colchicine is a drug we haven't talked about yet, and its mechanism of action is that it arrests microtubule assembly and inhibits many cellular functions and inhibits some neutrophil-related inflammation. It's kind of an obscure drug. It's still used for gout. It's got some issues with it. A lot of times people will say that your second-line therapies either are glucocorticoids or colchicine, and a lot of people are probably more comfortable with steroids than they are colchicine. Colchicine is sort of an interesting dosing strategy. You start out with high and then you level off the dose a little bit. You might see people on a daily low dose colchicine as well for people who get chronic gout attacks who aren't getting good suppressive therapy on allopurinol. And there aren't any trials comparing efficacy of NSAIDs to colchicine, so we don't really know specifically if one is actually more effective than the other. Adverse effects, GI-related, diarrhea, and abdominal cramping. It's contraindicated also in people using strong CYP3A4 inhibitors or people with renal or hepatic failure. High doses can have really toxic effects, and it can accumulate substantially in patients with those comorbidities. So again, a lot of people are hesitant to use it for these reasons. Certainly, it's still an option, and if your patient's relatively healthy otherwise, it can be an effective one. But NSAID, steroids, colchicine is kind of the hierarchy I've seen a lot of providers take, and I certainly wouldn't disagree with that. So if you want to do like a first, second, third line, your NSAIDs, steroids, and then colchicine would be your third line. And so here, again, I'm kind of contradicting myself here. But again, I'm just saying what I see in practice versus what the recommendations might be in a monograph or something like that. So anyway, NSAID is always going to be your first line. If NSAIDs are contraindicated, or if you have substantial joint involvement, I would go straight to glucocorticoids. With colchicine, again, falling somewhere in the middle. You might try colchicine on a patient, get great response with it, and be pretty comfortable with it. Other providers might really not like it. And again, there's a lot of those issues with colchicine. So you have to remember that these two steps are maybe a little bit interchangeable. So I'm not trying to be too wishy-washy here with my recommendations, but let's say somebody has hepatic disease or renal issues. Well, a steroid is going to be fine for a renal patient that's not renally eliminated. We aren't really worried about that. For colchicine, we wouldn't want to give it. So again, different things can work better for patients depending on what types of other comorbidities you're looking at. But at the end of the day, the strategy I would approach would probably be naproxen or ibuprofen. I realized I added an NSAID here. Naproxen or ibuprofen. So we've got our, oh, I'm sorry, I had naproxen here. I just assumed I had ibuprofen there. So I've been confusing you guys this whole time. So I meant to say naproxen when I was talking about the NSAIDs, that naproxen was the one that was studied in gout. So naproxen and indomethacin are the two that have been studied. But again, any NSAID's probably fine. So I'm sorry I said ibuprofen there. I meant naproxen, but again, it doesn't really matter. Either one's fine. So this is correct. Ignore me sometimes. But again, so naproxen is probably what I would start with. You could do indomethacin if you want, but naproxen is probably equally effective, over the counter, easy to get, cheap. And then I'd usually go to glucocorticoids in most patients and do colchicine as a third line option. But again, that's my personal preference. That's what I've seen a lot of providers who have some justification for that use. I'm not going to spend a lot of time on resistant or investigational therapy for gout because I think it's not super important, other than the fact that if you have really bad gout flares, there are some other things there. There's a drug called Kineret and Alaris. Alaris is $20,000 for a single dose. So there we go. Xanthine oxidase inhibitors, there are 2 on the market. They're used daily chronically to prevent recurrent gout flare-ups. They aren't going to be helpful, again, during an acute flare, but certainly chronically they can be helpful, and they inhibit the production of uric acid, ultimately, is what they do here. Allopurinol is the old drug here. It's been used for quite a few years. It's well tolerated mostly. It is renally adjusted, so you may run into issues with patients with renal dysfunction using this medication. The other drug is febuxostat or Uloric, which is a new medication. It's brand name only. It's not more effective than allopurinol, but it is okay to use with CKD patients. So generally speaking, no one's going to use Uloric because it's expensive unless they have kidney failure and gout. So then Uloric could be an option for them. Both may precipitate acute gout during therapy initiation. So if somebody just got over an acute gout exacerbation and they're done taking their oral meds, and you want to start them on allopurinol, just know that they might go into another acute flare. The reason that I bring this up is just because you can combine NSAIDs or colchicine during the start of therapy to help suppress that response. You can also test uric acid levels as well. Okay, that's gout. I have a couple slides here for pain management review with a couple example test questions that will hopefully give you guys some frame of reference for what I'm going to ask. All right, so this first one is DA, a 40-year-old man with metastatic bone cancer. He has been treated for chronic pain as an outpatient with long-acting high-dose oral oxycodone, aka OxyContin. He has been admitted for a procedure, and he's reporting that his pain is currently rated 10 out of 10. You want to start him on continuous IV infusion. Which of the following medications would not be an appropriate option? Okay, for a continuous IV infusion, is there any of these drugs that isn't available IV? So I'll give you a second to think about that. And that would be deoxycodone. So a pretty straightforward question. This is really important, I think, to understand. When you're prescribing medications, you really do need to know what they come in. And I think remembering that oxycodone along with hydrocodone don't have any IV formulation. So if you're converting, you always have to convert those over to IV and then convert IV back over to oral if you're going from one of those to the other one. All these all come in infusions. Commonly, we're going to see hydromorphone probably for continuous infusions is going to be the most popular. Certainly fentanyl.
Fentanyl can be used as an IV infusion for analgesia. A lot of times what you see more commonly is fentanyl as a sedative in like an ICU patient, but certainly it does have analgesic use if it's used in lower doses. And morphine can be used as a PCA2, just not quite as common. Morphine has accumulation of metabolites. It's renally adjusted. Dilaudid and fentanyl are going to be more popular alternatives, but certainly morphine would be an option. It's cheap, it's effective. All right, next we have SR, a 65-year-old female complaining of chronic joint pain in both of her hands. She's been a lifelong gardener and would like to be able to continue this hobby in her retirement. She has tried occasional Tylenol with minimal relief, and she has no evidence of inflammation that you can tell. Which option would be best for her today? All right, so hopefully, based on the lecture we just had, this is a no-brainer. The correct answer would be your scheduled acetaminophen. So I gave you a couple clues here. First of all, non-inflammatory. So that would mean that ibuprofen probably not is great right now. She's taking PRN Tylenol right now, not getting relief. So the first step should be let's schedule that Tylenol, max the dose out, and see if we can get you some relief with that. And if that doesn't happen, then let's go to something else. I'd be hesitant to add on another PRN because they're taking PRN Tylenol already and they're doing some other PRNs. It just gets messy that way. Scheduling ibuprofen again for a non-inflammatory process would be a second line thing. I would start with the acetaminophen first. And of course, narcotics would be our last line therapy. So we want to avoid a drug like Percocet for now, hopefully forever. Which of the following conditions would not be a reason to consider avoiding NSAID therapy? So talking about NSAID side effects and contraindications. This is a little bit of a tricky question. So we've got pre-hemodialysis CKD, hemodialysis, recent myocardial infarction, and recent gastric ulcer disease. So the process of elimination, hopefully cardiac events should be a very clear one that we aren't giving NSAIDs with cardiac events. Recent gastric ulcers, a recent gastric ulcer is something we want to make sure that's healed fully before we start any type of NSAID therapy. And now that leaves it with our kidney ones. Again, a little bit tricky. So think about somebody who's on hemodialysis versus somebody not. So somebody who is pre-hemodialysis CKD is still making urine. Their kidneys are still functional, but they're at risk for damage. So we want to avoid damaging them, and anything that's potentially nephrotoxic, like an NSAID, is something we don't want to give them. Somebody who already is on dialysis, we don't really care about their kidneys anymore. Their kidneys are shot. They're a great candidate for NSAIDs actually, because certainly there's other side effects. If they have heart issues or gastric ulcers, we'd want to avoid them, but for their kidneys, we don't really care about their kidneys anymore because their kidneys aren't functioning. They're on dialysis, right? So keep that in mind, that dialysis patients actually can take NSAIDs and can do quite well with them, assuming they don't have other contraindications. So again, A is the correct answer here. Oops. We have a kidney transplant, and kidney and heart transplant coordinator at our hospital who always likes to throw that at pharmacy students and residents because he always tricks them. So I'm passing on his wisdom to you guys. All right, this is LL. She's a 33-year-old female with a history of rheumatic arthritis who presents to your rheumatology clinic. She's been on methotrexate for 3 years. She has been experiencing some minor pain flares, and her dose was increased 3 weeks ago. For the past 2 weeks since the dose increase, she has been having significant diarrhea and nausea and has lost 10 pounds. So what's our best option here? A, continue methotrexate. Well, hopefully we understand that her side effects are not good, and we probably don't want to do that. So A is wrong. B, stop methotrexate and start hydroxychloroquine. Okay, so there's one alternative potentially. C, stop methotrexate and start etanercept or Enbrel. Another alternative. And D, continue methotrexate at the previous dose and add on etanercept. So this one's a bit tricky because she was on methotrexate for 3 years with good results, experiencing some minor pain flares, and her and her dose was increased 3 weeks ago. So the question now really is, where do you go? First of all, I don't think hydroxychloroquine is going to help. Methotrexate is a more effective agent, so I wouldn't go back in efficacy. I would go forward if I was going to add something different on. So the question is, do you keep methotrexate at a lower dose or do you stop it altogether? So this question is a little bit more tricky than what I'd asked on an exam. I would make this a little bit clearer. So don't get super worried about this because I think you can make an argument for either one. And the reason I did that was because it's a nice topic discussion. So here we go. We've got choice C. Choice C I think would be appropriate because you don't really know. You pushed her methotrexate dose, and it's likely a dose-related response is what she's getting. But at the same time, just decreasing her dose might not be enough to resolve her symptoms. So I think it might be good for her to stop the methotrexate for a brief period of time at least before you would add it back on. So I would say maybe stop methotrexate, start Enbrel. You could look at adding methotrexate at a low dose in combination later if you decide to do that. The other thing to think about, and why I would tend to go with C, is that you have a new drug you're introducing as well. So if you're just starting with Enbrel by itself, you're going to see the full effects of that. You might not need methotrexate. Maybe her symptoms are perfectly controlled with it. So in that case, you might think, well, what's the point of having methotrexate on board as well? However, so again, I would lean towards choice C in this situation. Choice D would be another thing. Somebody might say, well, let's go back on her methotrexate dose because it was working for her. She was side effect free, but she was getting the pain flares. So let's add on the Enbrel, and then hopefully that combination will help her. Again, both could be argued. I would prefer C, and again, on a test, I'd make this a little bit more clear cut with which one. There'd be one of these two and maybe some other oddball one that hopefully was incorrect, obviously incorrect. But again, just worth a little bit of a discussion on that one. Okay, thanks for listening, guys, and certainly reach out if you have questions before the exam. I'll see you Monday.